Okay, well, we have a really great evening planned for you tonight. For those of you, I see that there were several doctors who actually just jumped on, so I'd like to say welcome again to the Healthy Start CE webinar. We actually have a really great guest with us tonight. Before I tell you who that is, I'd like to mention that we would love to address your questions. So we are going to have an open Q&A, an interactive form at the end. So after you've heard the information, if you have any questions, please do not hesitate to ask. We'll be happy to answer. We have a great guest on tonight. I'm very excited. Leslie Stevens is a wealth of information, and the information you're going to hear is truly life-changing. So Leslie's actually been involved in the world of pediatric sleep, breathing, and airway for over 35 years. Leslie lectures and trains all over the world. I don't think that there's a subject in the reference to pediatric sleep, breathing, airway, and Healthy Start's connection that she cannot answer. And really, when you have the backing of a company like Healthy Start by Ortho-Tain, you have 51 years, you have over 4 million cases, and tons of research to back you. As CEO of Healthy Start, Leslie is most importantly a mother of 3. Her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. And one of the things that you'll learn tonight is that there is a silent epidemic affecting 9 out of 10 children. And unfortunately, this epidemic manifests itself in a variety of symptoms that can be easily overlooked, misdiagnosed, and left untreated. It's absolutely critical that we are evaluating children for sleep and breathing habits. Leslie's mission is to educate both parents and dental professionals to ensure children a lifetime of health, happiness, and success. So I'd actually like to take this time to hand the floor and the mic over to Leslie Stevens.
Thank you so much, Susie, and welcome. I am so happy to have you here tonight. And as Susie had told you, we have a great evening planned. We basically are looking forward to going through and talking about sleep, airway, breathing habits in children, and explaining how we identify, how we evaluate, and how we can look at the root causes and then be able to treat. So this is always so important, and we are looking forward to sharing this with you. I think I'm going to minimize this. I don't know why my camera is not working, but anyways, we can go on from here. So tonight we're going to be talking about what this all means to you. And when we talk, we're going to talk about a little bit politics, or maybe our ADA Dental Association, which has really been quite active and very vocal in this area. What we have seen last October 2017, at the ADA meeting, they actually put a policy into effect that basically requires each and every dentist to evaluate or screen for sleep and airway issues, looking at improper growth and development in these kids. So as we talk tonight, please keep that in mind, that these are things that the ADA has put into effect that each and every one of us should be looking for in children as we evaluate them for sleep. Whoop. Here we go. So as Susie had told you before, 9 out of 10 children suffer for one or more of these outward symptoms. And these outward symptoms are clues that basically give us kind of a look to explain to a parent what we're looking for, why we're looking for, what outward symptoms they can recognize, as well as what we can recognize not only as an individual symptom, but as groups of symptoms that might reflect more serious underlying root causes. So these outward symptoms that we will be talking more and more about are mouth breathing, snoring, tooth grinding, swollen adenoids, tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, peer problems, few friends, bedwetting, difficulty in school, especially in the subjects of math, science, and spelling, delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently waking up at night, sleep talking, and walking. And truthfully, this is a silent crisis among Americans' children. So typically, if a parent would identify one of these outward symptoms, they would probably address it individually. They might have a variety of different specialists that they visit if a child has, let's say, asthma, also allergies, maybe ADD and ADHD. So they go to a variety of doctors. And typically, we address each symptom individually with either medication, stimulant drugs, maybe psychiatric testing, counseling, therapy, surgery, sleep studies, allergy testing. It goes on and on the list. And what we're doing is basically only addressing the symptoms. I'm sure many of you and many parents don't realize that there possibly is a root cause for those outward symptoms. And unfortunately, when we look at the options that parents are currently looking at to help their children with these outward symptoms, they tend to be short-term band-aids. And many times they involve several drugs with many side effects. They can be costly, painful, time-consuming, and ineffective. So what is the root cause of these outward symptoms? Well, research over the past 20 years have linked each of these outward symptoms to a root cause. And it's mouth breathing, narrow palate, improper tongue placement, jaw relationships, and improper growth and development. So let's talk about screening for sleep. How does a dentist screen for sleep? But maybe also, how does a parent screen for sleep? So let's talk about some markers or some way of identifying maybe what's going on with the child. So let's take the physical characteristics to start with. Just looking at our child or looking at your patient will help you identify what's going on in a child. You need to know what to look for. So in these two examples, we see both children have dark circles under their eyes. Sometimes it's referred to as venous pooling. We also see the girl on the left. She tends to lurch forward. You'll see that children that have a tendency to have sleep issues tend to lean their head forward. Mouth breathing, getting more air, they tend to have that posture. The boy on the right, it's interesting. He's not a heavy boy, but actually he looks like he could be just because the way his chin is placed. Many times we'll see that the lower third of the face becomes retrognathic, or it tends to portray more of a double chin look. We also want to look at a child's profile. So if we take the girl on the left, if we actually drew a line from her forehead down her face, we can see, wow, there's a lot of lack of growth in that lower third of the face, especially in the mandible. We also see this rolled lip occurring, and you already know that this probably is going to reflect into a overjet of some sort. See how her lips are parted? More than likely a mouth breather. And then take a look at the child on the right. Again, take a line through that forehead down. Again, you can see how much lack of growth there is. But notice the shape of this child's lower portion of their face, mandible, chin, blends right into the neck. You also see a rolled lip, some separation of the lips, circles under their eyes, and you can kind of guess what's going on. These are not normal developments that we would anticipate in a child. And we're going to talk about maybe another screening device that a parent can use. So we love this HealthyStart sleep questionnaire because it basically goes over probably 27 of the most prevalent sleep issues. But not only are we going to identify them, we're also going to rank them in their severity. So each symptom will be ranked from 0 to 5, 5 being the most pronounced. As we go through this, it's a great tool for a parent, not only to help you identify what's going on in that child, maybe at night when you don't see them, but it also gives a parent a wonderful glimpse of maybe how these outward symptoms are related. We also see that number 27 on this listing is speech problems. Well, you'll notice that because more than likely the tongue is in the wrong position, tendency is the tongue lays low, probably not the right swallow, that there is a lot of lack of consistencies. There's a lot of lack of strength, and lack of endurance. And it really affects how a child speaks. The pronunciation is difficult. Sometimes you'll often hear that a child has not spoken until age 2 or 3. So these are kind of identification markers that you should pay attention to and alert a parent to so they know what they're looking for. An interesting study was done with over 500 children, looking at these sleep questionnaires and determining what are the most severe symptoms, what should we be looking for, are there relationships between certain conditions. And the results of this study basically indicated mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom study. 9 out of 10 children had one or more outward symptoms of sleep disorder breathing. 60% of the sample had 4 or more symptoms. 1 out of 5 children experienced bedwetting, which I want to point that out because I had no idea how prevalent bedwetting at a later age is. I mean, obviously, this would not be the topic of conversation. And many parents don't talk about it. But the statistic says it's about 18.7% of the children at an older age will bedwet. What that means is if you have a classroom of 20, you can anticipate 4 children are bedwetters at a later age. The last point is between 4 and 12 years of age, 92.6% of the symptoms will not self-correct, while 30% will worsen with age. That's a huge statistic. Basically, it's saying if you identify it, we're more than likely going to be treating it. There's always that wait and see mentality. Oh, I'm sure they'll grow out of it. It will improve with age. In this scenario, it is very unlikely that that will occur. So it's a very important statistic to make note of and also inform your parents. So continuing with the different outward symptoms that were identified, you'll see that mouth breathing basically was the most prevalent condition. 43% of the population, or the 501 children, presented with mouth breathing. And the reason why mouth breathing is so severe is because if we mouth breathe during sleep, just by opening up the mouth just a half an inch, that actually reduces the airway by 6 millimeters. And in a 7-year-old, you'll see that the airway is only 7 millimeters. So that means that poor child is trying to breathe through 1 millimeter of airway at night. And as you probably know, REM sleep requires oxygen. Is that child getting enough oxygen if they're trying to breathe through 1 millimeter of airway? No. Will that child more than likely not experience REM sleep? More than likely. So these are the important concepts that we're going to be talking about tonight. Also, if a child mouth breathes, we will tend to see 7 to 8 other outward symptoms that basically are associated with that mouth breathing symptoms. So if we look at some of the most frequent symptoms found in children that mouth breathe, you'll see snoring, 53%, difficulty listening, talks while sleeping, allergic symptoms, fidgets with hands, restless sleep, teeth grinding, and feels sleepy and or irritable during the day. So the implications of this study is basically the findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. Begin treatment as early as possible to ensure permanent changes. and identify outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. So let's talk a little bit about airway and how critical this is in the conversation of sleep and breathing. As we talked about before, a 7-year-old typically will see or have a 7 millimeter airway. So what we try to envision that is we're trying to create an airway that would resemble a garden hose. Unfortunately, when we have mouth breathing, sometimes skeletal issues that impact the development or the diameter of the airway, a child is basically trying to breathe through a coffee stirrer. Coffee stirrer kind of resembles that 1 millimeter of airway space that we had talked about with mouth breathing. I don't know if you've ever tried breathing through a coffee stirrer. I tried one day. I thought, let me see what these kids are experiencing. So my anticipation was to try to go the whole day breathing through a coffee stirrer. Well, I lasted about 10 minutes, maybe 15. And I'll tell you, I had the most massive headache I've ever had. And I tried everything to get rid of it during the day, and it just would not go away. So understanding what that feeling felt like, I can imagine how difficult it is for these kids. Unfortunately, many of these children have only experienced this type of breathing or sleep or airway issues, and they don't have the mechanisms to explain to us what it really feels like or if they are not feeling well. So it's the job of our parents as well as the dental professional to be able to identify this and basically be the oral physician that you studied so long to be and address not only the dental conditions, but the overall health of a child. So what are the contributing factors that have created this situation that we see 9 out of 10 children exhibiting? Well, it's a few things. Prolonged use of pacifiers is one of them. Prolonged use of nipple bottles. Both the nipple bottle and the pacifier, basically, when a child uses, it creates suction in the mouth. And that suction can actually constrict that archway. Well, if we have a narrow archway, we don't have the proper space for our tongue to be in the palate of the mouth. I will say right now, when we talk about placement of the tongue and where it should be, when we say the letter N, where that sound ends is where the tongue should be at rest. So we maybe in our audience tonight have more problems than just what we think our patients are going to exhibit. You yourselves might have a tongue that's not in the proper position, but not to worry, I have something for you as well. We also look at the lack of breastfeeding. Obviously, breastfeeding is very important, but also just the ability to breastfeed helps develop the oral cavity. Sometimes when we talk to parents, they say, well, I was able to provide breast milk to my patient or to my child, but I wasn't able to breastfeed. So that's great. You know, breast milk is wonderful, but missing out on that actual ability to breastfeed impacts the oral cavity. And then when nipple bottles are used to obviously provide breast milk, it compounds the problem. So you can kind of see where we're going with this conversation. Another area is soft diet. Unfortunately, most of the food that we feed our children, here's one, graduate puffs, the nutritious snack that melts in a baby's mouth. Unfortunately, we're not feeding them a hard diet. A hard diet helps with the occlusion, it helps develop the arches, and most of the food we serve our children are soft in nature. I mean, how many times do you have a child that says, oh, Mom, I want that steak to be as tough as possible. I'd really like to chew a lot of it. So we know how absent a hard diet is in many of these children's diets, maybe even some of ours. And the soft diet really doesn't help in the development of that oral cavity. So what are some of the other things we can identify with extended use of pacifiers, consequences of prolonged nipple bottle use, and thumb and finger sucking? Well, it's the open bite. How many times have you seen a child with an open bite similar to this? Right now, you can tell they have a tongue thrust. They're a mouth breather. These are all things that we're going to help you identify so that you can basically get to the root cause of what's going on with these kids. Airway. Let's have a conversation just basically just where the nasal cavity is, where the hard palate and the soft palate meet. Tongue placements. We'll talk about airway. This is just a good graphic to kind of get an overall scheme of what we're talking about. So much of our conversation, we talk about mouth breathing, but really the nose is such an important conversation or a part of this conversation. Obviously, if we are trying to eliminate mouth breathing, we're trying to encourage nasal breathing. And the reason being is the nose has 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane traps dust, pollen, bacteria, and other foreign matter. It contains receptors which sort out odors, and it aids in pronunciation and the quality of voice. These are all important qualities and properties that we need to make sure that our children are basically receiving. How many times do you see children that look like this? In the car seat, mouth open, exhausted. Well, again, we saw that mouth breathing is present in 43% of the population, and that was done on the study of Stevens and Bergerson. So this is what I say is going to be the aha moment for you. We realize that children mouth breathe, and many times parents, or maybe even you as a dental professional, have never really understood the degree of problems that mouth breathing can occur or can create. So I want you to take a listen to Eli and see what happens with this mouth breathing and see how we can rectify it.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. This has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. And I open his airway. Just bring his airway forward. There we go. Now he's breathing through his nose. I've got his airway. I'm opening his airway. Just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. This way. Hear how quietly he's breathing. You don't hear him anymore. And all I did is gently bring his jaw forward.
That's quite something, just to see by eliminating the mouth breathing, bringing the lower jaw forward, how different that child is sleeping. Do you think he's getting oxygen? Yes. Is it getting the proper amount? Absolutely. And this is one of the properties that HealthyStart is going to be addressing as we talk about treatment of these children and looking at the underlying. So obviously, as he stopped breathing, and you noticed when he tried to regain that air, he would turn his head away. And we see that the body compensating for the deficiencies that are occurring. So when we talk about airway, let's talk about exactly what's occurring. So we have 2 5-year-olds. They're 2 different patients. On the left, you'll see a constricted archway or airway. And please notice, obviously, these are cephalometrics. So they're done in a vertical position. Obviously, when we sleep, things will get worse. So sometimes we like to say a Ceph, a CBCT scan probably is going to give you the best image of the current situation. So on the left is a constricted airway. On the right is what we're looking to have, and that's more of a normal airway. If we look at the effect of mouth breathing, you could have a child that you took a cephalometric and the airway looks great. Oh, he looks like he has a normal airway, but he has all these outward symptoms of sleep, breathing, and airway. And we want to figure out what could possibly be going on. Typically, it will be a habitual issue, meaning that it could be the mouth breathing. Remember, we talked about just opening the mouth by a ½ an inch will basically reduce that airway by 6 millimeters. So you can see how that opening can constrict. Now, this is the same patient as we look at what the effects of mouth breathing can be. So talking to a parent, we talked about trying to create a garden hose for an airway as opposed to a coffee stirrer. Another way to talk about this airway issue, especially if the child mouth breathes, is to show what an ideal airway would be. And this is a 7-year-old boy. You can see the 7 millimeter diameter, and that would give us 100% airflow. Well, when we mouth breathe, we basically eliminate 6 millimeters of airway, reduce it down to 1 millimeter, which is basically 11% of airflow. That's such a small area, but such an important visual to provide to your parents so they can kind of understand why this is so critical for them to address as soon as possible. Here's an interesting case. And in this particular example, we have a HealthyStart patient that started in the very first appliance that typically will be the habit corrector. And this habit corrector was placed in this patient's mouth. At the onset, we took a CBCT scan to see what the airway's diameter was. And we found that this particular patient, who is 9 years old, is 53.6 square millimeters. Now, average airway is usually determined by the age of the patient starting at age 5 times 10 will give us our airway measurement. So this particular patient is 9 years old. So if we did the equation 9 times 10, we would anticipate if he had a normal airway to be 90 square millimeters. As you can see, he's deficient. What's interesting is our airway will continue to develop up until age 17. And at age 17, our airway should be around 150 to 170 square millimeters. At age 21, our airway starts to deteriorate over the course of our life. So it is critical that we reach our potential in order to have the airway ability to compensate for the duration of life and the deterioration that can occur. Well, this particular child began at a compromised airway of 53.6 millimeters and was able, with 1 month, wearing the appliance in his mouth, took a second CBCT scan and found his airway to be 337 square millimeters. Now remember, on an adult, we anticipate seeing 150 to 170. That means this is almost double what we would anticipate seeing in an adult. So again, here is basically the scale where he started at 54 square millimeters. We anticipated at age 9 it to be 90 square millimeters. After 1 month use of the habit corrector, with the habit corrector in the mouth, the second follow-up CBCT scan measured 337 square millimeters. Now that is 6 times greater than what we had a month ago. So it's a interesting conversation. It's also such an interesting conversation that we're able to develop an airway that is so much more substantial than what we would ever anticipate, even at the peak of adulthood. We are in the process of research projects that are fully evaluating this, but also looking at the longevity of these kind of conditions. So it is quite an interesting conversation. So let's go over what we have talked about. Mouth breathing and snoring are usually results of extended bottle feeding pacifier use, poor tongue position and abnormal swallow, maybe sugar processed foods, soft diet, poor oral habits, thumb, fingers, lip sucking, tongue thrust, etc. Mouth breathing and snoring can lead to a compromised airway. And a compromised airway reduces the airway, restricts airflow, reduces oxygen, increases CO2, affects brain function, immune and endocrine systems, swollen adenoids and tonsils, creates low tongue position, tongue thrust, creates underdeveloped dental arches, especially the overjet and open bite, and cross bites. Now, a compromised airway will lead to sleep disorder breathing. And sleep disorder breathing includes restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmares, daytime drowsiness, aggression, defiance, anger, difficulty in school, and frequent ear infections. I will make a note. We tend to interchange the word sleep disorder breathing to sleep-related breathing disorders. And they're basically the same. The ADA, when they put that policy into effect, coined the word sleep-related breathing disorders. Obviously, both of them are interchangeable. When you talk to a parent, when you mention the word disorder, it is disheartening for them. Nobody wants to hear that their child has any type of disorder. So again, I wish we came up with a better word. Maybe we'll just say they need a healthy start. But anyways, those are a few comments. So let's talk about what happens when we have lack of sleep. Taking an MRI, the first series of images are of a normal night's sleep. So you can see the red and the yellow indicators of brain activity. Now look at the second set of MRIs, and this is brain function with 1 night of sleep deprivation. It's very difficult to see any type of activity, and you can see a small area here. So you can just obviously see the huge impact lack of sleep has on the brain function that occurs. So let's talk a little bit about HealthyStart and what we're looking to accomplish and how we're going to make those changes. HealthyStart is a division of Ortho-Tain, which has been around for, we're on our 52nd year. And to date, we've treated over 4 million children worldwide. So we've been around. We're always investigating research on the growth and development of children, even looking at adults as well. I will say that we start treating children as young as 2 years of age. Actually, we have 5 patients that are 13 months old. And our oldest patient is 84. So even though most of tonight is really focused on the young child with growth and development, please understand we can also look at adults. With adults, obviously, there is no more growth and development. So we have to realize that habits have been ingrained. But what it basically means is if we wear an appliance each and every night, we can obviously enjoy better airway, better breathing, obviously improved sleep. And these are the things we're talking about. When we look at children, we look to the underlying root causes, and we look to treat, but treat in a more permanent fashion. We would love to be able to address these issues and allow a child without any type of retention to be able to live a healthy life without relapse, without any issues, that the most helpful or healthy oral cavity that we can create. So when we start with a HealthyStart system, the first appliance typically that's used is called a habit corrector, and it does exactly what the name says. We are actually going to look at the habits and address those. And as you noted in the study that we did, mouth breathing is the number one outward symptoms or habits that we want to address. So as the HealthyStart and the habit corrector is first implemented, as well as the other appliances that we use, we're basically going to be addressing the root causes. And these root causes are expanding the dental arches. We see in many situations, at least 50% of the cases will have a restricted or constricted dental arch. Establishing nasal breathing, obviously that means eliminating mouth breathing. We will train the tongue. We want the tongue to be in the right position at rest, as well as the proper swallow. Eliminate bad habits. This includes everything from thumb sucking to mouth breathing to eliminating open bites. We want to advance the mandible to correct overjet. We want to encourage proper facial and body growth, since lack of REM sleep impairs function of the adrenal glands to secrete growth hormones. And we will correct most orthodontic problems. An interesting conversation is typically orthodontic issues are another form of outward symptoms of sleep and breathing. For so many years, we focused on straight teeth, and we love straight teeth. Everybody wants to have a beautiful smile, but we take it one step further to your health, a patient's health, a child's health. That's probably the number one criteria. We're going to address that and eliminate those outward issues that we see and allow that child to have the proper night's sleep, the proper breathing, and basically develop that airway. And guess what? HealthyStart, frosting on the cake, we're going to straighten their teeth at the same time. So they go hand in hand, and it's a great combination. So you're all saying, well, they're removable appliances. Oh, they don't work, this and that. We've been around for a very long time, and I feel that we are extremely proficient in compliance and as well as success and collaboration with both the parent and the patient. We had 2 independent research studies done, and they found a 94% cooperation rate with the HealthyStart system. So I don't really concern myself too much with cooperation, and we'll talk about how we get these great statistics because we're clever. We know how to talk to the kids. We know what works. We know what gets them excited. And the most important part is they're going to be feeling great. The kids will become self-motivated. Many times our problem stems at the end of treatment when the child doesn't want to give up the appliance. So we can talk about that problem at a later date. So habit corrector, the built-in myofunctional therapy. What makes the habit corrector or the HealthyStart habit corrector so unique? It's because it has the built-in myofunctional therapy in each of these appliances. And what that means is that the features of this appliance are going to aid us in both addressing, identifying, eliminating improper habits, creating the proper habits, providing the proper architecture so that the oral cavity has the basis. in order to function properly. So we have initially these palatal tabs, which basically aid in the expansion. The tongue will push against them to start the expansion of the arches. We have these, what we call lingual shelf, or I kind of refer to it as a ramp, because as the child swallows, the tongue will be lifted and put in that proper space. Remember, we talked about the letter N and where that sound ends. At the same time, we will have these prongs that basically prevent a tongue thrust, but also indicate to the patient when to retrieve that tongue. We also have these lingual tabs. And what this does is, remember when we saw the child open their mouth to mouth breathe and that lower chin drifts back? This will prevent that from happening. At the same time, if a child has a large overjet, it will bring that lower jaw forward so that we're opening up the airway for that child. We also can add pads to the habit corrector, and these pads act as an activator to help close the open bites more quickly. So these features, there's a tab that actually also hooks onto bedclothes. We can use it also to help strengthen the lips. Obviously, the appliance will also prevent mouth breathing and encourage nasal breathing. So why is this so effective? Well, every time that child swallows, we reactivate or basically allow that therapy to occur. So at nighttime, we swallow 1 time a minute. During the day, we swallow 2 times a minute. So just by wearing this appliance at night, we basically repeat that pattern, that proper pattern, almost 500 times each and every night. So that is a huge benefit, because can you imagine with that many repetition, how quickly these changes occur? Another important aspect that we need to identify is the proper swallow. So how do we see how that child is swallowing? Well, there's a very good mechanism, and that's basically just watching them drink a glass of water. If you have the ability, I would put just a cup of water on your operatory and have that patient and that child pick up, maybe tell them, wow, you look pretty thirsty today. You probably had a pretty tough day. Why don't you take a glass of water? And as they take that glass of water, watch what kind of facial movements occur. If they have a proper swallow, we would anticipate no facial movement, only movement of the neck muscles. If they have an improper swallow, you will see the face contort in order to make that swallow. So something like they might perch their lips, but they will move their entire facial structure to make that swallow. So as you're going through the HealthyStart treatment, I would make sure at every appointment you look at that swallow and see how it's improving. There is a study that's coming out. It was a sample size of 220 patients, and basically it was with the use of the habit corrector for a period of 5 months and the percentage of correction that you can anticipate. So for instance, let's take the first one, headaches. 18% of the sample presented with headaches that represented 40 children. We saw a 98% improvement of these cases. We saw mean correction of those improvements 94% of the time, 91% mean correction of the entire sample, 85% of cases with 100% correction. So you can see we put this together because we want you to understand what we anticipate seeing in these children. And if you're not seeing it, we need to have a conversation to find out if there are other things going on with that child. And we also have an ability to understand how quickly some of these symptoms should be correcting, and we can indicate that to a parent as well. This is always my favorite conversation, is really about sleep disorder breathing and ADD and ADHD. As we all know, as anytime you turn on the television, we hear literally how ADD and ADHD has really taken over our children's lives. So many children are diagnosed with this condition. But what's really interesting to me is It's not a blood test. It's more of a list of criteria that we basically evaluate to see where that child falls. Well, we also realize that sleep disorder breathing uses the same type of criteria in order to identify sleep issues. So the question is, can they be misdiagnosed? Absolutely. Most recent research shows that 85% of the children with ADD and ADHD have sleep disorder breathing. That's a huge number. My suggestion always is, if a child seems to portray a lot of the behaviors of ADD and ADHD, evaluate sleep first. It's easier to identify, it's easier to address, and if it is a sleep issue, we have the ability to make a more permanent change for that child. One of the most impressive studies on ADD and ADHD was done by a woman named Karen Bonnick. She studied over 13,000 participants, and she found that sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. ADD and ADHD patients have little or no REM sleep, but have delta sleep. Patients without ADD or ADHD have primarily REM sleep and delta sleep. And in our study, we found that ADD and ADHD was present in 25.2% of the cases. So here are some long-term effects of children who are diagnosed with ADD and ADHD. 50% are held back 1 grade, 30% are held back 2 grades. Well, if the child is actually suffering from sleep issues, we can hold them back 10 grades. It's not going to change what we're seeing in that child. It needs to be addressed. And if it can be addressed in a more permanent fashion, imagine the barriers that would be removed for that child and the progress that child could make. Children who are diagnosed with sleep disorder breathing and sleep deprivation, who do not rectify the situation, the long-term effects basically show a reduction in IQ by 10 to 20 points. In my world, that means maybe not going to college. Well, the study went even further to put a dollar amount on what an IQ point would be worth during the lifetime of a child, and that's $170,000. So these are some big numbers, some worrisome statistics that basically maybe evaluating sleep first would solve a lot of these issues that we see that we are currently discussing. So how does the Healthy Start promote the growth and development? Well, as we know, normal craniofacial growth is in a forward and down direction. We understand so much growth happens at very early ages. And that's why we typically say we love to look at children prior to the age of 12 in order to make these more permanent changes. And that's simply because at age 12 years of age, we already see 89% of the male population have completed their growth, and 94% of the female population has finished their craniofacial growth. So this is why we always look younger and younger, we can get more growth and development. So why are we talking about growth and development? Well, take a look at this patient. At 5 years of age, you can see how she has the underdevelopment of the lower jaw. And you can see with the Healthy Start treatment, 2 years later, how much forward growth has occurred. We actually have seen, and we've done research studies that have indicated with the Healthy Start appliance, we get 54% more growth and development than the control sample. We can talk about a few additional appliances that we use even to promote further growth and development. Many times we'll see a deficiency in both the maxilla and the mandible, and the Max A Corrector will actually move that both upper and lower jaw in a forward direction. If you can take a look, this appliance has no frontal wall, and it has 3 tabs in it. So as the tongue is pressed against it, it actually moves that upper arch in a forward direction in order to promote the growth. And at the same time, the lower portion of the appliance brings the lower arch in the forward direction. So you can see initial, you can see 1 month, you can see current. This is obviously a child in the process. They will go on to the other appliances in order to more fully develop that arch as well. The class 3 is another condition that basically impacts the growth. So with the class 3, and we're typically talking about a pseudo class 3, with the skeletal, we will make changes. We say we more minimize the skeletal. With the pseudo, it's much simpler process. So as you see the lower arch impacting the ability for the upper arch to grow and develop. So what this appliance does is, again, the appliance has no frontal wall. We use 3 tabs similar to the Max-A to push against in order to drive that upper arch in a forward direction in order to make that jump. At the same time, there is a lip bumper that's positioned in the lower portion of the appliance to hold the lower arch as we make that jump. And as soon as we make that jump, it's almost like we restart growth. And you will see both arches moving in a normal fashion after that jump is made. So treatment planning, we do have a diagnostic service. So we will help you look at your cases and diagnose them. This is a new area for most doctors working on young children. It's a new area, even looking at sleep, breathing, and airway. So we offer these services so that not only are you going to be evaluating these patients, but you're going to have almost a consultant in your office who is going to help you with planning those treatment plans and getting the most advantageous treatment for each and every one of your patients. So let's take a look at the cases and see what we're looking at. So here you'll have a child that is actually 7 years of age. Obviously, you can see numerous initial symptoms, fives, restless sleep, wets the bed. You can see all of these. Well, the Habit Corrector, the first appliance in the HealthyStart system, was initially used, and this is 3 months later. You can see basically almost every symptom has rectified itself. Look at the speech issues that this child had. Very delayed speech, didn't say many words up until age 3 or 4. So obviously a child that is struggling. So let's take a look at him and his dental arches. You can see the deep bite that he had. You can see the squareness of the arch. And this was in March of 2015. So let's see how he progresses. So here's about a year later, a little bit more. You can see the changes that have occurred in his facial structure. The overbite has been corrected. Look at the roundness and the expansion that occurred in both the upper arch and the lower arch. And let's see how that child progressed in the stability of the case. Here he is. You can see how nicely the case has come together, how wide the arch is. Look at the lower arch. Look at the nice finished case. This child is actually going to remain in what we call retention. He'll probably wear the appliance a little bit until he's probably about age 12. We want to make sure all the incoming teeth rubbed in properly and the stability is there for them. So let's take a look at another case. Again, here's the sleep questionnaire. You can see some 3s, some 5s, 2s, 4s, quite a good array of different outward symptoms. And again, here the symptoms look after the Habit Corrector 3 months later. Basically everything except here he has a little bedwetting, still maybe 1 night a week. You can see where he was initially and where the progress is. We would anticipate the bedwetting to go to 0, and obviously we still have further ways to guide the rest of the dentition in within this case. Here is a third case. You can see the initial. Here's the finish. Here's the comparison of the two, initial and final. Dramatic. So here's the case. You can see the initial is a model. You can see how deep the bite is. Here it is, the patient in the appliance. You can see how the permanent centrals are coming in angulated. The appliance captures them, guides them into place, and here is the finished look with the appliance in the mouth. Another case, before, after. Another case, before, after. This is an interesting case. This particular child, her mother actually had very similar characteristics as her daughter. And unfortunately, nothing was done until her late 30s, where she had to have jaw surgery, and obviously a lot of other issues that went along with it. Noticing the same characteristics in her child, she opted for earlier, better. So this particular child presented, you can see rolled lip, deficiency in the profile. You can see the deep bite. There was teeth grinding. You can see the arches are not rounded. So a HealthyStart was started, and here she is. What a difference. Take a look at her facial. It almost looks like almost a different child. Look at how the deep overbite has been corrected, intercuspation, roundness of the arches. Now let's show you what this stability looked like in this patient. So I'm going to show you two more as the progress as the child gets older. And these are done without any appliances. Here she is. You can see the dentition holding beautifully. Again, later on. So you can see the stability that occurs within these cases. Another case, snores, bad breath, ear infections. This patient actually is from Alaska, and you can see the initial, and you can see about 1 year later. Again, outward symptoms of sleep have eliminated, and you can see the dramatic changes that have happened in the dentition. Here's another case. You can see, again, numerous outward symptoms, speech issues. You can see the initial, you can see deep bite, you can see how the occlusion is improper, and you can see this is approximately a year later. The overbite is much better. You can see the arch. You can see how this was square and now it's rounded. And most importantly, we see the differences in the sleep. This case is still in progress. Obviously, we're waiting for further teeth to develop, but you can see where they're heading. Another case, initial, had a spectrum of issues, snored, Brooks. Here's mid-treatment. And here he is 14 years later. The case stayed. The stability, it's a wonderful finished product. So today, HealthyStart, as I said, has treated over 4 million cases. We want you to understand how seriously we take the safety of our patients, as well as providing you with the safest appliance that we can provide. All of our appliances are regulated to a Class 2 medical device, meaning that we are only required to regulate ourselves to a Class 1, but we go ahead and go that extra mile because we want you to understand the seriousness we take with the safety of these appliances. So a Class 2 medical device basically means we can take our device and put it in the body and not cause harm to the body. Obviously, we wouldn't do that, but that's how safe the appliances are. Please realize that our appliances are USA made, FDA cleared, no latex, no silicone. All appliances are BPA and PPS free, phthalate free as well. I will just briefly tell you a little bit about ROI using this. And this is probably worst scenario. And we wanted to not be as dramatic, but still show you how amazing what this is what HealthyStart can do for your practice. So average HealthyStart treatment fees, we see anywhere from about $3,700 to $4,500. Sometimes I see more, sometimes I see less, but something in that range. If we look at the amount of time that the system takes, the habit correction usually averages 3 to 6 appointments during that period of treatment. 20-minute appointments. In our office, we usually did a little bit less, but let's give the worst scenario as opposed to the best scenario or the most impressive scenario. So if we said at the most 6 appointments, 20-minute appointments, that's 2 hours. We look at the orthodontic conditions, and that would be the second and third appliance, and typically 6 to 8 appointments, maybe 30 minutes. The appointments are relatively short. We're going to be measuring few of the conditions. We're going to be talking to the parent and obviously, hopefully high-fiving them and giving them the congrats. So let's say worst scenario, 8 appointments, 30 minutes each. That's a total of 4 hours. So the total chair time is 6 hours. I would say typically I would anticipate a 3-hour rate for these treatment cases, but maybe at the onset, these are some numbers that you want to maybe follow. The percentage of doctor time required by each appointment is less than 20%. Typically, I say 10%. Total average doctor per patient is 1.2 hours. The doctor's average hourly production is about $37.50. So that means if you treat 200 patients a year, and obviously that's about 8 patients per month, that would bring in a revenue of $900,000. If you take these numbers and divide them in half, obviously you can see the hourly production rate will increase, and obviously the total revenue would remain the same, but the amount of hours to obtain it would be less. So this is a great tool just to kind of get an overview of what HealthyStart can do. So let's just talk about the advantages and uniqueness of the HealthyStart system. It's an early treatment, realizing that 9 out of 10 children are affected, meaning 40 million children. We also know, as we said to you, if you see it, treat it. We already know 92.6% of the cases will not self-correct and 30% will worsen. The appliance and the treatment is really a 3-dimensional treatment. We're going to address all dimensions. We're going to do expansion of the arches. We're going to treat the improper habits. We're going to create the proper habits. We're going to promote the growth and development, and we're going to address the orthodontic and functional problems that are occurring. Each appliance of the habit correctors has a built-in myofunctional therapy activated by a swallow. The appliance is completely removable, meaning that child can brush their teeth. You will not see decay that occurs, any of those problems associated maybe with more of a fixed solution. 92% of the cases finish to a class 1 occlusion and do not require additional orthodontics. This can also be considered as stage 1 plus of a full orthodontic case. These appliances correct orthodontic conditions at a rate of 0.8 of a millimeter per month. Less appointments, less chair time for the doctor, and obviously greater profitability and referrals for the practice. So hopefully this gives you kind of an overview of what we are looking at. I think I saw a couple questions, or maybe one question here. And let's see if I can get this to open. Susie, I can't seem to get this question.
Oh, that's okay. I can help you with it. So the question is, how many weeks or months between your appointments during habit correction and ortho correction?
Oh, great question. So with the treatment, obviously we're going to start treatment as soon as we see issues. So that could be at age 2, it could be age 4, it could be age 8, it could be age 10. Obviously, it's when the patient walks into your office. So let's start with age 4. So with a child that is age 4, we're going to start with the habit correction. Now, the habit correction typically at the very, very minimum would be worn maybe 2 months. But in a 4-year-old, we're going to have them continue wearing the habit corrector appliance simply at night when they sleep up until we see the very first permanent tooth starts to erupt. And, you know, it's hard to estimate, but I would gauge at maybe at 5.5 or 6. So that means the habit corrector is going to be worn for a pretty lengthy period of time. Now, typically appointments, I would say at the beginning, you probably want to see the child every month. And the reason why I say every month is because you want to really get a handle on what they are doing and make sure they're wearing it how they should appropriately each and every night. If they're struggling to keep the appliance in the mouth, we can do some tricks to help them, but we really want the body to basically adjust to the HealthyStart appliance and gauge and strengthen so that it can use its own properties to hold the appliance. Now, once we see the first central tooth start to erupt is when we're going to move into the second appliance. And that second appliance is geared so that as the teeth erupt, it's going to guide the teeth into the proper alignment by moving it downward and basically putting natural pressure on the adjacent teeth. And that's how we're going to expand these arches. As the arches are expanding and the laterals start to erupt is when we're going to move into the third appliance, which is typically the final appliance because it's designed in a mixed dentition, but it is going to provide the guidance so that the incoming teeth will be guided into position. At the same time, these last two appliances will be addressing the functional problems. So it will be addressing any overbite, any overjet, open bite, gummy smile, class 3, deficiency in both the upper and lower arches. So it basically is going to be doing everything at the same time. And what's kind of interesting is in these young children, they only need to wear it passively when they sleep. Now, if we have a child that's older, say 8, 9, that have more permanent teeth in the mouth, we are going to start with typically the habit corrector as the first appliance. Now, if there is some conditions that we are concerned with or we feel that it immediately needs to start, we can combine those first two appliances, meaning that the habit corrector could be worn at night and the second appliance, which is designed in order to straighten the teeth but also help expand the arches as well as correct the functional problems, will be used simultaneously. Or we simply use the habit corrector until we see those habits diminish, and then we move into the second appliance. So during that diagnostic and that treatment planning, we will actually help you and say, this is the timing that occurs. Step 1, step 2, step 3. This is when you are going to move into the next and the next. If we feel that there is reasoning between or encouraging that we have the ability to address both habits at the same time as well as straightening teeth, we will indicate that to you as well on your treatment diagnosis. If we look at a young child, say age 2, that's going to be a much more lengthy treatment. And typically we would start with a habit corrector and have that child wear it all the way up until the time their first permanent tooth starts to erupt. And that means you'll probably typically see that child one each month at the onset. And then as you go through, you would see them at their 6-month cleaning until that first permanent tooth starts to erupt. So hopefully that answers your question in regard to being able to figure out the timing. But please realize that the diagnostic service is there as your consultant, so that we want to be able to help you and to indicate when those when that timing is the most appropriate, and how we can address these issues in the best way possible with the best combination of appliances with the most appropriate appliance that should be utilized. So with that, I don't know, Susie, if you want to take it from here and talk a little bit about what the next stages will be.
Absolutely. And I was going to mention too that, that one of the great things is that I'm going to talk to you a little bit about, how you get involved and how you get started. And one of the great things about that is part of what we do, or a big part of what we do, is we actually ensure that your entire team is trained as well. So a lot of that chair time that you're talking about, Leslie, is actually the office and the hygienist that's actually doing that chair time. Most of that chair time, or not much of that chair time, is really doctor time.
No, and it's designed that way so that as a doctor sees a patient that comes in, obviously the most critical time is when we switch from appliance to appliance. I would also say the consultation and maybe the first few appointments. If you feel that you are not as adaptive with children, or maybe you feel that there's someone in your office that really relates well to these kids, it would be a great opportunity to make them basically the go-to person in the HealthyStart system. We see that quite often in an office, and they're able to monitor. We have staff manuals that help and are able to provide the structure, the protocol for the office, to help them with what do we do in each appointment, when do we set up that appointment, and we have an app that helps with this. And Susie, I think you're going to talk a little bit about the app as well. So I won't go into that and have you get started then. So take it from here, Susie.
Perfect. Absolutely. So sorry. I'm always have the habit of not unmuting myself. So yeah, I'll tell you a little bit about some of the different things that we offer here at HealthyStart. I mean, really our goal is to ensure that every one of our doctors is successful. Our mission, our goal is to ensure that every child has the opportunity to be assessed. And so our digital education course is actually a perfect platform for that. It's a 6-session platform, or 6-session series rather. The nice thing about it is it can be taken from anywhere in the world. Everything is recorded, but we also have hands-on interactive as well. So it's kind of a combination of both in a couple of different ways. So one thing is the policy that Leslie was talking about at the beginning, that ADA policy. This course actually complements that policy, which is fantastic, because the policy basically says that it is up to every dental professional to assess children, but it's the responsibility of that dental professional to find the education and to get the education to assess those kids. And so that's what this course is all about. So the great thing about this course is that you actually receive 2 full cases. So HealthyStart wants you to not only receive the education, the knowledge, but we also want you to actually treat these 2 kids so that it's a simultaneous learning. And so it's fantastic. It's a great way to learn. But these 2 cases are great because you actually receive that treatment plan that Leslie was talking about. You receive all of the appliances that you need to treat that child from start to finish. You receive specialty appliance cases to put the appliances in for the kiddos. And you also receive the HealthyStart mobile app. So Leslie was talking about that mobile app just a little bit. Basically, the mobile app is a compliance app for the kids. It's actually a really great way for you and that child and that parent to actually connect and interact. So through that app, they can not only, of course, earn great prizes and things like that for wearing their appliance, which is always great, but also they can actually send you photos through the app. They can fill out new sleep questionnaires through the app. They can do all kinds of neat things to actually, so you can create that connection. You can even put in when their next appointment date is, and they can find all of that through the app. So it's really great, and that actually will come with your cases, which is great. So those 2 cases right there, I mean, I'm guessing you already have 2 children in mind that have issues. They have these symptoms. It's difficult. Once you learn this information, it's hard not to immediately start realizing and thinking, wow, I see these kids every day. So these 2 full cases are already a return on investment for you, because that's a potential $7,400 worth of treatment fees. So $3,000 voucher to also attend one of our destination courses. We want to give you 2 different ways and 2 different platforms to learn. So we have our digital, but we also have live lectures as well, and we have those all over the country. And so you can actually come to one of our live lectures, and you can actually bring 4 of your staff members as well, which is very awesome. I mentioned that this digital course covers you and your entire staff, because we want all of you to be trained, from the person who answers your phone to the person who's cleaning the teeth. We want everybody to know what you're doing, understand what HealthyStart is, so that you can all kind of be on the same page and excited about helping kids in this way. You're going to receive an acrylic stand with sample appliances on it, so you have those appliances to be able to show parents. And then every Friday, we actually have an interactive study club to go along with the series that you've been watching throughout the week. The study club is great because we actually bring on different guests every week to talk about different things. So for example, we'll bring on billing specialists one week. We'll bring on implementation specialists. So every week there's somebody different that's going to talk to your staff members, that's going to talk to you, that's going to really, again, our goal is to ensure that our providers are very successful in what you're doing with HealthyStart. You're going to receive training on pediatric treatment of sleep-related breathing disorders and how to identify it in your patients, how to use HealthyStart to increase your patient flow. You actually earn 18 CE PACE credits for the digital course, and then 16 more when you attend the destination course. It's kind of cool because we had a live course just recently in Denver, and it's a packed house. Our digital education class, we are training hundreds of doctors each course that we have, and I think that the sentiment is that these doctors are excited because they're not just assessing children, they're actually treating children, and it's huge. That's huge when you can when you have a system where you can actually do something to help these kids. So here's a couple of things that doctors are saying about HealthyStart or the digital course from all over the world. A doctor in Australia said that our digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor from Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. And Doctor in Colorado, I've really enjoyed the course. We've identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he's had swallowing problems, and we've already seen great improvement in his eating. We already have 3 more patients who are ready to start next week. I love that one. This is a doctor in Colorado, and she was in her 3rd week. So I mentioned it's a 6-session course. She was in her 3rd week, and she already had parents lining up at her door. And the reason for that is because when you sign up for this course, we're going to actually send you those starter appliances immediately. So you're going to have those habit correctors. You're going to receive a 2 different age groups so that you can treat 2 kids, so you have 2 different experiences. So you will have those habit correctors in your hand. You'll be able to hand those to those 2 children that can start using them immediately, and their parents are going to start noticing a difference. Suddenly they're sleeping better, their health is changing, it's amazing. It's very amazing. So they're of course going to tell their friends, and before you know it, you have parents that are contacting you wanting to know if you can help their children. So ADA actually took this course and they said it was ingenious. So that's very high praise. So financial metrics, startup cost analysis. So typically our courses are $3,400. So our digital course is $3,400, and our destination, our live course, is actually $400. But for tonight, we're actually running a webinar special for you guys. I know a lot of you guys actually met Leslie and stopped by our booth in Chicago. So at the midwinter meeting, so we wanted to offer you guys a promotion. So we're actually going to be doing both courses for the price of one. So $3,400, and you can actually attend both courses, and it's everything I talked about. It's huge. It's actually, I always think about everything our doctors receive with this course, and the fact that you're getting 2 free cases and all of those kinds of things. And I just, it's amazing how generous HealthyStart is, and again, it's because we want doctors to be involved. We want you seeing these kids. We want you treating these kids. So we actually have a course starting April the 1st. There's a couple of ways that you can get involved. You can either visit www.openairwaydentistry.com. Just click on the Register Now button that you'll find on the website, fill out the enrollment form, and you're done. That's all you have to do. We'll receive your information, and we'll actually send out your welcome package, including your 2 habit correctors, pretty immediately. You'll receive an acrylic stand, just everything that you need to get started. And then on April 1st, we'll actually start sending you out your first series, and you'll be receiving all kinds of different things in between to kind of get you started. If you have any additional questions, or if you're not wanting to sign up electronically, you can contact me directly at slafredo@thehealthystart.com. So, reach out to me. I'll be happy to answer any questions that you have. We are excited. We're excited about what we're doing, and our courses are fantastic. So we really would love for you guys to be involved. Leslie, is there anything that you'd like to add?
No, I think you did a great job. I excited that all of you were able to join us tonight, and I look forward to you participating in the digital. It's a great way to kind of kick off the new year, start treating new patients, looking at the children that you have currently in your practice, and realizing that there are so many children out there that have these symptoms and are unaware, and that you truly can be a leader in your community to educate these children, and most importantly, treat and allow them to have healthier lives. So I wish you a wonderful evening. Please don't hesitate to reach out to us if you have any questions. Susie, thank you so much for everything you've done. Great information.
Yeah, thank you, Leslie, for being with us tonight as well. And I mean, just providing such great information, important information, for all of us. So I appreciate it. And doctors, thank you guys for taking this time to spend the hour with us. Your CE credit will be emailed to you, so keep an eye out for that. And I will keep an eye out for your enrollment, so we can get your welcome packages sent, and we can get you guys started. So have a great night. And Leslie, thank you so much again. Have a great night.
Good night, everyone.